devices or put them on silent mode during presentation to minimize distractions. We encourage the audience to actively engage after the presentation and maintain decorum.
I request the chairperson, Professor Pradeepa M. and Dr. Veeresh K. Chandra and the speaker, Dr. Mithun S. to take seat on the stage.
I request Dr. Shripati D, Professor, Srinivas College of Pharmacy, to florally welcome Professor Pradeepa M. and Dr. Mithun S. We have with us Dr. Veeresh Chandra, Professor, Department of Pharmaceutics, Srinivas College of Pharmacy, Mangaluru. He has completed doctorate from Srinivas University under the guidance of Dr. A. Asha Baraya. We have with us another chairperson, Professor Pradeepa M, Principal, Srinivas Institute of Nursing Sciences, Valachil, Mangaluru. Sir has completed BSc in Nursing from Raju College of Nursing, Hassan, RGHS, Bangalore, and MSc in Community Health Nursing, Raju College of Nursing, Hassan, RGHS, Bangalore. Currently pursuing PhD in Nursing under Srinivas University, Mangaluru. Sir has 15 years of teaching experience.
I request Sir to introduce our speaker, Dr. Mithun S., Associate Professor, Department of Psychiatry, Srinivas Institute of Medical Science and Research Center, Mukka, Mangaluru, to the gathering and to chair the session.
Very good morning to all. It's my honor and pleasure to introduce Dr. Mithun S. Dr. Mithun S, MBBS, MD, DMD Psychiatry, is an assistant professor in the Department of Psychiatry at Srinivas Institute of Medical Sciences, Mukka, Bangalore. Sir is a psychiatrist,
extensive experience and diverse academic background. Dr. Mithun completed his MBBS from Kempegowda Institute of Medical Science and pursued MD in Psychiatry from St. John's Medical College, Bangalore, as well as DNB in Psychiatry. Additionally, he holds an MRC Psych from Royal College of Psychiatry, United Kingdom. His professional journey includes roles such as junior resident in the neurosurgery department at Kempegowda Institute of Medical Science, Bangalore, research associate in ICMR project at St. John's Medical College Hospital, Bangalore, focusing on autism spectrum disorders, and senior resident in the Department of Psychiatry at BGS Global Institute of Medical Science, Kengeri, Bangalore. Apart from his clinical and academic responsibilities, Dr. Mithun served as the member of Secretary of the Institutional Ethics Committee at Srinivas Group of Institution and is a member of Medical Education Curriculum Committee at Srinivas Institute of Medical Science, Bangalore. Sir has presented and published numerous papers in prestigious conferences and journals. Dr. Mithun is also recognized for his contribution to community health awareness program and has received several awards for his academic excellence and cultural achievements. Today, Sir will be the speaker on the topic of fiction-based psychological learning for professional ethics in patient care. Okay, with this brief introduction, I welcome Dr. Mithun S. for this gathering. Over to you, sir.
Hello. Yeah. Good morning, everyone. Good morning, everyone. Yeah. Firstly, I would like to thank Srinivas College of Pharmacy, Dean Sir, Shabraya Sir, convener, co-convener, coordinator, the organizing committee, and Satish Sir, and the volunteers, and also my chairpersons Pradeep Sir and Veeresh Sir, for giving me this opportunity to be a speaker and share my viewpoints with the pharmacy students. And secondly, I would like to congratulate Srinivas College of Pharmacy for holding such a wonderful conference in association with the Indian Pharmaceutical Association Mangalore branch. And Dean Sir walked through the poster presentation, the art making, and also it is a wonderful job done by the volunteers. The number of posters were more than 200, and it's a commendable job. And I would like to, I think you deserve a round of applause for yourself, a big round of applause for yourself. Yeah. Then, lastly, to begin with my presentation. So, this presentation is called fiction-based psychological learning. So, what is this presentation and what is the fiction? How can you learn from the fiction? Basically, the anime and the cartoons. And what is the role of a psychiatrist or a psychologist in pharmacy training? I am actually in touch with some of the pharmacy students. Some of them are here. Some of your seniors, Dr. Vilas, and some of the fiction was suggested by your batchmate, Dr. Srijil. Then now Dr. Nagnatna. So in the coming slides, I'll be telling what is it and what is the rationale behind this everything. So in the beginning, the MC told that after the presentation you can interact, but I would suggest during the presentation also you can interact. Any doubts if you have to ask or anything, and you can do so. So my layout of presentation is basically because this is the 6th National Conference of Innovative Practices in patient training and in clinical training and patient safety. So my layout of presentation, my objectives will be how, with the help of fiction, that will help in your clinical training and patient safety. So for this, when I discussed, so the audience will be mainly pharmacy students, B Pharma, D Pharma, and pharmacy students. When I had a discussion with Satish sir, so I just gave an idea. So what is it that can be relevant and which is like understandable to you, which you can take home? Message was like, then sir suggested me a few tips. So I went through your website, Indian Pharmaceutical Association, and most of you are very well aware of this more than me. So in that website, I went to the GCP guidelines. So that is a good clinical practice guidelines. So in that, it is a collaborative guidelines made by multiple authorities and apex bodies. As you can see, the Ministry of Health, MOH, DCGI, and the ICMR has drafted guidelines for research in human subjects. And this GCP guidelines came into picture at the national level by these apex bodies, but as a part of the international collaboration after the Declaration of Helsinki, the WHO guidelines and ICH requirements for good clinical practice. So good clinical practice will be both your practicing of your clinical training and also the patient safety. How that is relevant to your branch is basically, I'll be explaining in the coming slides. So ICH GCP is nothing but International Council for Harmonization of Technical Requirements for Pharmaceuticals for Human Use. Guidelines for Good Clinical Practice GCP, which is an international agreed standard that ensures ethical. So because I was part of the ethics committee, and this is very much relevant to me, and also because ethics need to be practiced in your course, in your syllabus, your practicals, and also your research projects, everything. So these guidelines I thought will be relevant for you, and to explain certain principles of these guidelines, linking that with evidence-based psychology via fiction. I felt it was very relevant and innovative way of putting across my ideas about these principles to you. So, ethical and scientific quality in designing, conducting, regarding and reporting trials that involve participation of human subjects. The latest guideline is E6R3 released on 19 May 2023. But the current version, which is there in the website if you have seen, that there are about 13 principles with respect to the ethics research, is E6R2 released in 2016. From which I have taken the principles. So what is the role of a psychiatrist, or how a psychiatrist speaker or psychology in pharmacy is important, because it's mainly concerned with the ethics. So what is the ethics? Ethics is mainly concerned with your thoughts, which is related to the mind, and we are the mind specialists, so that is where we come into the role. So as you can see, ethics is about your morals, morality, about your values, the dilemma, the complaints, benefits, choice. And ethics, just before my presentation, there was a presentation about communication skills, how you counsel a patient. So counseling again comes to a part of the psychological training. Psychiatrist also comes into play there. So not only ethics need to be followed in the communication skills, communication is your verbal as well as non-verbal communication skills, but it's also ethics need to be followed in your practicals, in your pharmaceuticals. These are the subjects which you know in your semester-wise subjects it is there. So quality assurance and biostatistics and research methodology, where obviously ethics are followed. That's why we have an ethical committee. And your project work and clinical trials. And very much important, some of the poster presentations which we were going through in the morning were also about some of the clinical trials or some of the extracts or how they have done interventions, not only observation, not only KAP studies, but also intervention studies were there, where also you need to follow the ethics. So drug discovery and clinical evaluation of new drugs, whether it is in the drug discovery phase, preclinical evaluation phase in the animal phase, or the clinical trial phase, where actually the participants will be human subjects, human participants, and your phases of clinical trials and pharmacovigilance. In all these aspects, ethics plays a very important role, and ethics, not that only psychiatrists have the upper hand in ethics, but we have a role in teaching the ethics, because it's about the thinking, about the mind, and so that's why a speaker of psychological qualification or a psychiatric qualification might be relevant in this context. So that is the link between psychology and pharmacy, and PharmD students are also posted in psychiatry, where we teach them, they observe and learn how to counsel the patients, and whatever is relevant to them, the ethical part, they do observe that, they learn from that. So this is the link between psychology and pharmacy. So now coming back to this, now during COVID time, it was a very hard time for all of us. So during that time we were in isolation. So we had to do the hospital duty, we had to counsel the patients. So patients who are in the ICU, we had to wear a PPE kit, and then we had to go and counsel the patient. They can't see our face. So sometimes they get scared because we are like a ghost when we wear the PPE kit. You would have seen it circulating in the WhatsApp media. Person goes in the PPE kit and patient gets afraid. So that was a very tough phase. So during that time where we are not in touch with our family members for nearly 6 to 7 months, we were in isolation. So during that time, I was needing some source of inspiration that, as you know, most of them are very much, they watch the anime, cartoons, fiction. So you may not read your syllabus, but you have a list of what anime you have to watch. All of you are subscribed with Netflix, right? Not all of you would have gone through the website which I mentioned, your Indian Pharmaceutical Association, but all of you are subscribed to Netflix, OTT or Hotstar or anything. So you are well versed with that. So same thing with me. So then during that time I was writing a narrative review for my promotion for my publication. Then I got an idea. Then while I was going to the YouTube, I just came across Shark Tank. So then I thought, why not, instead of making a review, why not making it into a YouTube channel? Then I applied to the copyrights for the Government of India, and I got my copyrights regarding my idea, that is healthy aging by fictional spirituality with play and relaxation therapy. So now my subscribers, most of them are students, some of them are pharmacy students themselves. So, and there are about 900 subscribers. I'm not promoting my channel, but still, you can go to the channel later, I'll share the link. So basically, if you see that, I have explained many concepts about with the help of fiction like Joker, what is chaos theory. Chaos theory, especially during COVID time, some of you whom you have lost your loved ones or your family members, how you can come across or come out of it. So some of them I've explained with the help of the cartoons. But for this presentation, with the help of the anime, I'll be explaining 13 principles about your GCP guidelines with the help of certain relevant anime, which I have watched. Probably most of you would also have watched it. So first principle is about ethics. So why has ethics come into picture? So basically World War II, everyone is aware of that. During that time a lot of human trials were done which were unethical. So to make streamlining that, just because some group of people in some part of the world they were unethical, they did not stop the human trials. They told that human trials are necessary because progress needs to happen. For that they put that the ethics forefront, that is 4 pillars of ethics are autonomy, beneficence, non-maleficence and justice. So for that, they put a declaration of Helsinki. In that, they told that you can do the pharmacy, you can do the human trials, no matter in which field, whether medical, pharmacy or any other, but there needs to be certain guidelines which need to be followed. Why? That was based on the thought with the hope that what mistakes were happened in the past, that does not repeat again in the future. So that is when your Declaration of Helsinki came into picture and good clinical practice guidelines in the form of ICH-GCP. So the principle behind this was the hope. In psychology, especially for psychology students, we tell this, hope is one of the first virtue of Erikson's psychosocial development. So hope is also very important virtue for to come out of the depression also. So in this context, hope plays a very important role, that hopefully you don't commit the same mistakes which had happened during the past, so that just because someone stumbles and loses their way, it doesn't mean they are lost forever. Sometimes we all need a little help. So that help is from the ICH-GCP guidelines. So whenever you're following the human clinical trials, we should not lose the hope of harming the patients, but you need to follow the guidelines and do the clinical trials. So this is a beautiful scene. I don't know how many of you have seen this. This is the clipping from the movie X-Men Days of the Future Past, and it's a very beautiful scene. And this is my video which I have explained in my YouTube channel. Second, so now we know what is ethics, why ethics has come into picture. So basically, the simple bottom line principle behind ethics that majorly it has to be good. It's like democracy. See, what is the majority in our country rules us. So whatever trials we do 100% it cannot be, foolproof. See, we can be experts. All of us can be experts in our own respective field, but we cannot be perfects, except for Amir Khan, who is Mr. Perfectionist. But we can only be experts in our field, so mistakes are bound to happen. But majorly, if it is good, then we follow those ethical guidelines. So majorly, if the benefits which are in the ethics which you are following, if the benefits are more than the risks, which usually you assess in the drug discovery phase or the preclinical phase in the animal experiments, if the benefits of the drug or the extract of the drug, pro-drug or the active drug is more than the risks, that is when you need to carry on with the research, because that is what is research. In Kannada they say pratyaksha kandu pramanisi nodu, means what appears, face validity. So you may see, say during the COVID time, they may say if you take lemon water, that will kill the coronavirus. That is in the face value. But for other things, you have to go and do a research. You may not know what is going to happen. So that is called the first impression effect. That is on the lines of Beauty and the Beast. I think all of you would have seen the movie. Beast, when you look at the beast, you may feel because it's ugly, that beast may be harmful or dangerous. It can be other way around also. If the person is beautiful, that person, you may think the person is good and very sober. Need not be so. That's why that's called the first impression effect, attribution bias. So bias is something which happens in research where ethical principles need to be followed. So this first attribution bias can be overcome when you have a strong protocol where the benefits should always outweigh the risks of the clinical trial. So who had ever thought that this could be true, that he's no Prince Charming, but there's something in him that I simply didn't see. So first time when you see, you may not find something, or first time when you see, you may find something. But to find that causal relationship, so always give time to beat the first impression effect to overcome this first attribution bias on the lines of Beauty and the Beast. So that is the second slide. So next, now you have seen the drug discovery phase, the pro-drug phase. You have seen that the benefits is better than the risk. So now you have to try on the human subjects. So, but humans are different from animals. So you have to empathize with the human subjects. So that empathy, one of the ways of empathizing is called a mature defense mechanism called self-observation. For this I have taken an example of Tom and Jerry. I think all of you would have seen Tom and Jerry. I think even our senior professors during childhood days, they would have seen Tom and Jerry. There's no one who has not seen Tom and Jerry. Has anyone not seen Tom and Jerry? See, everyone who has seen the Tom and Jerry. That is the reason I have taken fiction, because how the job is done. It's because I'm able to connect with the people, especially with the students, because it is a universal thing now. Now everyone watches fiction, anime, and it's easy way to communicate. It's a part of our therapy called superhero therapy. I won't go into the details of that. That's for the psychological students which you do. So self-observation, what happens in Tom and Jerry, Tom always troubles Jerry. But when the dog, Spike, comes and troubles Tom, so that time Tom realizes that what trouble I was giving to Jerry, when the spy gives to me, I should stop. So he starts empathizing. It's called self-observation. You start putting yourself in other shoes. For example, if you bully your junior, if you rag your junior, when your senior comes and rags you, that time you realize what ragging you have been doing, so that is wrong. So that time you start empathizing. That is called self-observation, mature defense mechanism. So with this you are able to empathize. So whenever you are doing a drug trial on a human subject or your human participants, when you put yourselves in their shoes and see that in case I am taking the drug, the benefits may be better than the risks as per the preclinical trial, but will that cause any harm to the patient? So always the empathy should be better than your experiment results. So your experiments may show that the benefits more than the risk, but if it is not for the patient safety, then it should not be done. That is what is the ethical principle, that's called empathy. So this is the third principle as per the GCP guidelines. So be good to get good. So what you give comes back to you. Next is, obviously now once we have done the preclinical trial, now you know there is some research question and you identify a research gap. So next has to be your further review of literature. So the review of literature, you may find some research idea that you like it. So what happens that when you go and keep doing more and more research, that research idea may not fulfill a research gap. So you may emotionally be connected to that research question, but logically there's nothing which can come out of it. So that the thing which you need to do is your common sense need to prevail over your sixth sense. I think all of us have only 5 senses. Does anyone have a sixth sense? That's called gut feeling. So what you feel, it's called emotional reasoning. I think this may be correct. I think if I write for this question, if I write this answer, I may get more marks. So that is called gut feeling. Sometimes that may work in your viva or in your theory papers. But in ethical practice of your research, your common or logical sense. Common sense is basically the sense which is common in terms of research. That is your ICH, GCP guidelines which you need to follow. So your common or logical sense should always prevail, not always, majorly should prevail over your gut feeling or sixth sense, because your gut feeling or sixth sense may be misleading. Cognitions derived may be emotionally driven than logically driven. So you should empathize with the patients. You should be emotionally connected with the patient, but not with the research question or not with the research gap. That should be logical connection. So you need to have a proper logical reasoning after a thorough review of literature before you proceed with the protocol. So see that line, Mona, this is from the Mona, Disney movie Mona. So see that line where the sky meets the sea, it calls me and no one knows how far it goes. So similarly, when a research question, you get an idea. See, you can get research ideas, anything under the sun you can do a research. And when you get a research idea, as I told, the first impression, you need to give more time, you need to give more efforts, put in more efforts to know what is the outcome of that research idea. So then further, you have to do a further review of literature and further try to understand what is there. So unless you put in your efforts, unless you do a further research, that's what happens, your bachelor's, your master's, then your master of philosophy goes on. So more and more you advance in your educational qualification, the more and more you need to transform yourself not only professionally but also in your personal experiences. So that is what the fourth principle, that information what you gain should be more rational, logical rather than emotional or gut feeling. So principle is medical education. I know Aparna ma'am knows about that. So competency based medical education. The curriculum of MBBS during what we learned after it was the 1987 draft. So nearly after 30 years they have changed now it is to make it competent. So competence in psychology, the definition of competence is, there is a elaborate definition, I won't go into the detail of that. But your whatever trials you are doing, whether that is on par with the other trials. See, no one expects you to be, your trials should be super or exuberant but it should be at least be competent enough to come into the poster or for a publication or as a part of your thesis. So for that, for competence, you need to have a good quality evaluation. So failure is the stepping stone for success. So I think all of you would have seen the movie The Dark Knight. So why do we fall? So that we can learn to pick ourselves up. So it's only by experience is the best teacher. So when you fail, you try to learn from the mistakes what you have done and correct those mistakes. See, it's but human error to do it's but a human nature to do errors. It's called error, trial and error. So when you do the errors, you learn from those errors so that you don't repeat the same mistakes again. So mistakes are still acceptable, blunders are not acceptable. That's what is called negligence. Your ADR, all those things, that is where your ADR monitoring, everything comes into picture. So, if your competence, you should be competent enough to evaluate not only theoretically or also but practically, so that during that evaluation you may come across many failures, but still you have to overcome that to be competent enough with the other, on par with the same university or with the other university or other nationally or internationally. Usually we do with children in counseling, it's called superhero therapy. With children we cannot do cognitive behavioral therapy, CBT or REBT, they won't understand. So 7-year-old or 8-year-old kids, same entire thing so tomorrow don't start wearing a mask and then because sir has told in the conference, I'm just giving the example. It's a rhetorical example, that's all. So the competence can be learned from certain fiction, that is the basic idea behind this. Next, so once you have done the evaluation, then you know project work, there's a deadline. You have to submit the project work. Now our PharmD students know who those who are in final years. So now within a certain time we have to submit our project work. There's only 3 months time. If you don't submit, then Dean's will question us, they'll put fine. All those, that time you try to tweak your results, or you go to the statistician. You go to the statistician's house, you stay there with the statistician for 2-3 days to get the evaluation done. So you try to be non-compliant with the ethical rules, but it always takes a willpower, your will, to be compliant with the GCP guidelines, so that your trials need to be effective and also competent enough. So willpower, Captain America in the movie First Avenger. So we may not be perfect, as I told, none of us can be perfect. We can be only experts. Expertise is the goal. So when we may not reach the ultimate goal, but closer to the goal is the aim of that. So we may not be perfect, but the safest hands are still our own. So our hands may be safe with us, but when we are dealing with the other patients especially, we have to take care of their safety also. So for that, being compliant with your ICGCP guidelines in terms of the research protocol and other your regulations, whatever your etiquette needs to be followed, for that takes a lot of willpower. So that willpower can be, one source of inspiration is Captain America. You know the famous dialogue, I can do this all day. So I can speak about this all day, but the time limit is only about 30 minutes for me. So it's about willpower. That is the 6th principle, compliance, which you can learn from that. And this dialogue, this is my favorite. This whenever I am down, I look into this, and everyone knows about this. So responsibility. So whatever trial you do, whether it is a success or a failure, you are responsible for that. You cannot put the responsibility on your teachers. So my sir told, my ma'am told, so you cannot just shun away your responsibility. Vicarious responsibility. So you cannot do that. Whatever you are doing, you should take responsibility for those actions. So you are the decision makers of your educational qualification and also the decision making of the life and the safety of the patients on whom you are doing the trials. So with great power. So you have the power of what? Knowledge of your pharmaceutical practice, and which needs to be come into effect in your attitude. So that attitude in terms of empathizing with the patients, which it has to come into practice in the form of ICH, good clinical practice. So with great power comes great responsibility. So that is based on the fidelity virtue. Fidelity virtue means faithful. You have to be faithful to your professional ethics. You have to be faithful to your guidelines. So that is what is called professionalism, professional ethics in your ethical guidelines. So no matter what, you may be going through a lot of difficulties. You have to segregate that, and you have to be professional when you are in the professional setting. Okay, so because you are the decision making of, sometimes this decision making may be a life and death situation for the patients also. That is what is called your ADS or idiosyncratic or your negligence comes into picture. Your penalizing code, all those. So principle 7 is the responsibility. You should take the responsibility of that. Next is your qualification. So I think all of you have seen Lion King Simba. So what is the purpose of you doing the research trial or your clinical trials or your B Pharma, D Pharma? Is it only to obtain a degree? But what is the ultimate purpose in your life? So that you be of service to the community. So if you have a purpose in your life, that gives you some degree of satisfaction, also gives you a particular clear goal where you have to go through. So the purpose is, look inside yourself, you are more than what you have become. So as I told, professional courses are called professional courses because there is a certain level of professionalism which needs to be followed, and that change can happen right from your first year to final year. So that change happens as you grow in your knowledge, you grow with your age, you grow with your maturity, you grow with your wisdom also. So the ultimate purpose, if you have a purpose in your life, that you have to make a good clinical trial. With that, if you get a patency and if you get the patent of the product, like similarly what I have done with my concept of copyrights. So if you get a patent and if that patent clicks, then the rest of your life, your purpose of your life is served, and your future generations, your family, you can take care of them well. So if you have a particular goal, if you have a purpose, that is what is Shark Tank, all the startups or everything they promote. Some of them is for the TRP also, but practically if you look behind the idea behind that is to promote idea generation, so that there is a purpose which you serve for the betterment of the human society and the civilization. So this can be learned from the Lion King Simba. You know that he gets lost and goes away from his kingdom, but later he gets reminded by his girlfriend, that is Nala, telling that you have to come back to your kingdom and rule the kingdom. So that is your purpose. You have to become the king. That is called the circle of life. So similarly, when you have a purpose, you will get a purpose in your life, and that completes the circle of your life. So that is the principle 8, qualification. Whether you are qualified to serve the purpose which you are actually supposed to do, and the purpose may be served to you or given to you from the university, but what is your personal purpose, you need to look into yourself. Principle 9, Avengers Endgame. So when you know there is a good clinical trial, and you know the benefits are always better than the risk, and it's also safe for the patients, but you cannot force any research on the patients. You should participate in the patient. You should participate in the research. No. That is what, against that, that's what happened in World War II. That's why the Declaration of Helsinki came into picture, where the autonomy of the decision making to be a part of the research is with the patients. So you cannot say this research is inevitable to the patient. It is left to the patient whether they can snap their fingers or they sign for the consent. So it's left to the hands of it's left to the decision making of the patients. That is what the principle behind the consent, that you could participate in the research. It's not that you should participate in the research. You could participate in the research. These are the benefits, these are the risks. So if you want to drop out, you could also drop out from the research. So that autonomy is a part of your ethical principle, which is a part of your GCP guidelines. So don't be like Thanos or being should, that where he had to erase the half of the universe. But be like Iron Man of being good. Even Iron Man also could do the same thing. Whatever infinite stones he got, he could erase the half the universe, but he did not do that because he could do that. But he chose not to do that because that was the ethical thing which he had to do. So similarly, when you are taking the consent for the patient, you have to be transparent about your research and give all the patient information sheet to the patient and do the research not only in your project work but in any of your practical aspects, your practical subjects like your pharmaceutical, industrial pharmacy, and all the other branches, your semester-wise subjects. So principle 10 is the data. So data, finally, what is ultimately the outcome of your data, of your research? The data is what is your power. So you have to protect your power. You have to fight for your data. So always when the publication happens between the students, there is always, I am first, put me as the first author, put me as the second author. So fighting always happens there. So whoever has put in more efforts, whoever has put in more ethical efforts, that person should be in the forefront. So that care should be taken. Your data should be carefully handled, because once you get the data, you can play with the data. But that care about the data needs to be there in terms of data collection and also data analysis and data projection also when you are doing a publication or making a poster presentation. So the power of data comes in response to a need, not a desire. Just because you want to be first author doesn't mean that I need to be first author, just put my name. That's not going to happen. You have to put in your efforts, you have to take care of your data, you need to get that power of the knowledge so that you are in the forefront. So that is what the principle has to be. That is the 10th principle. The data collection, analysis and projection should be ethical. So this can be learned from Dragon Ball Z. Principle 11 is confidentiality. So confidentiality, when you are public, poster presentations, when you know the principle is that you should not reveal the data of the patients because nothing has to be made public. That is one of the principle behind this. And when you are taking the consent of the patients, also confidentiality need to maintain. But there are certain grounds where you have to breach the confidentiality, grounds of breach of confidentiality. So that wisdom when to breach the confidentiality, that can be learned from Kung Fu Panda. That is what I have told. There is always something more to learn even for a master. That's what I told. See, learning is a lifelong process. In CBME, for one role of the IMG, Indian Medical Graduate, is being a lifelong learner. They say student life is a golden life. So if you learn for the entire life, so your entire life can be golden life. Theoretically, that's what it goes, as the saying goes. So the wisdom can be learned from a lot of quotes. There is a famous quote, yesterday is history, tomorrow is a mystery, today is a gift. That's why it's called the present. So make use of the today's time and don't waste it. And that wisdom of maintaining the confidentiality also. Same thing happens with your placebo or nocebo. See, placebo response is something which a patient feels. To make something special, you just have to believe it is special. So when you give a drug, patient may improve within 1 or 2 days, but you need to have the wisdom to know that, see, the half-life of the drug or the plasma half-life, the steady state, and the onset of action of the drug is about 7 days. For example, in psychiatry, it's lithium. So one patient, when he takes 1 dose of the drug, he feels, I am 100% okay. But a wisdom should tell that, no, that's not going to happen, because the onset of action of the pharmacodynamics of the drug itself takes about 1 week. So why is this improvement happening? So this analysis comes with wisdom, and that can be learned from this fiction, along with the confidentiality. That is the 11th principle. Then good manufacturing practices, that is, you always need to affiliate. Why there is an affiliation? See, every college needs to be affiliated with the university needs to be affiliated with the national apex body. Affiliation is for like seeking help. See, as I told, no one is perfect, so there is no harm in seeking help. When you don't know, it doesn't make you small to tell that I don't know, please tell me or please teach me. That's why learning is a lifelong process, because there's always something or other things to learn. So as you go by, once you pass out, you may get the degree, but that wisdom and that maturity or the knowledge may still be in the process. So always affiliate with the apex bodies for good manufacturing practices. That's what we can learn with it's a kind of mature defense mechanism called affiliation. See, that's what seeking professional help. This especially we say as an awareness for patients or students with depression. If you are going through depression or anxiety, don't keep it to yourself. Come and seek the professional help. Shankarinda Bandar Tirtha, they say. So some advice may be given, what advice we give. Similar advice may be given by other friends also. But professionally, we are expertise in our field, so the way we advise them may touch to them rather than others advising them. So there is no harm in always asking for help. So do not be fooled by its commonplace appearance. Let's, like so many things, not what is outside, but what is inside that counts. So on the outside, on paper, your research may be perfect, but inside, you may know that these are the loopholes. For that, you need to ask help how to overcome that. So for that, you have your teachers, your seniors, and your other affiliation affix bodies. That is the principle 10. That is, for good manufacturing practices, always affiliate yourself with competent people. The last one is, all of you know Naruto. Naruto's son is also there, Baruto. I won't go into his son. So now quality assurance. Quality assurance is like, how will you ensure a quality? See, quality, you may think what you have done is the best. No matter what you do, for your teachers, it's always like you can do much more better. So the thing is that it's called fallacy of fairness. Hard work is worthless for those who don't believe in themselves. So do your part, what you are supposed to do, follow the ethical guidelines, follow the rules, regulations which need to be followed, and do your part. Be process oriented rather than being outcome oriented. Because the outcome of you cannot guarantee, you cannot predict what is the outcome of the research at the beginning of the research. It may be either way. It may be positive or negative. So don't be disheartened by even if it's a failure. As I told, you can always learn from the failures. So just be process oriented. If the process is fair, and if you're fair enough with the process, definitely the outcome also is going to be fair to you. So that's called fallacy of fairness. Be fair to yourself. Be fair to your work rather than expecting the world to be fair to you. So that ends my presentation. Thank you all. Any questions? This is the link of my YouTube channel. This is my part of the promotion. So if you have liked this presentation, you can go to this and like, subscribe, share, and don't forget to press the bell icon. Thank you. Over to the chairpersons.
Now the session is open for the delegates. Any queries? Any questions? You can ask the sir. Sir has shared his view in evidence-based fiction therapy, related to mental health. So, fiction therapy it helps to explore the patient feelings, views, thoughts, as well as it helps to improve the communication skill, and it helps to increase the self-awareness, right, sir? Then it helps for the emotional healing. Then also it helps for the individual and group therapy.
Yes, yes.
Sir, I have one question myself.
Yes, yes.
So, as a psychiatrist, you have seen many different kind of psychiatric disorder or different kind of psychiatric patients. But for which patient this fiction therapy is very suitable? Neurotic disorder or psychiatric disorder patients? Which kind of patients?
It's mainly for the neurotic disorders patients, especially in the children age group. See, because in adults we do cognitive behavioral therapy, CBT. There is something called as we identify there's some schemas, automatic thoughts, and everything. But with the children, when we start doing that, they won't understand it. So especially your 13 years and above, especially 13 to 19 years of age children who are still considered children as per the pediatric age group till 18 years of age. They are adolescents, anyways we can say young adults also. But above 13 years of age till 18 years of age, this is very much relevant because they are able to understand. Below 13, they may watch the cartoons, but what is the principle behind that? If I explain to them, they won't understand. So with less than 13 years, we mainly do with the behavioral therapy that is called play therapy. Ata pata uta. During our times, that was the thing. So pata jate utanu ಮಾಡಬೇಕು, nutritious food, and also ata. Play is a form of therapy with the children. That's why if you see pediatric wards or psychiatric wards, there's something called as a play room for the pediatrics. And if you go meet some pediatrician in private clinics, they have certain play things for the children. So play is a form of therapy. So this is mainly beneficial for 13 to 18 years of age. But I think many of the pharmacy students, they themselves watch the anime cartoons and everything. Some of them were suggested by some pharmacy students also. So when students have neurotic disorders like depression or anxiety or like exam fear, in my channel also I have explained how to overcome the exam fear or stage fear, how to talk in front of the stage. So with the help of the fiction, I have explained that. So when depression, when we communicate to them, if we ask them, like for example Batman, so we ask them, they are able to connect with it because they are emotionally connected to the cartoons. Your kids at home, they watch cartoons. What is the reason children watch cartoons? Because they have that fantasy thinking. So with maturity, that fantasy thinking slowly changes to reality thinking. But during that transition stage, if you are able to impart certain values about, say, on evidence-based psychology like Erik Erikson's, so this can be taught in those neurotic cluster of people, especially between 13 to 18 years of age. I myself am 37 years of age, but I still watch cartoons. My parents they still ask, why are you still watching it? They won't understand what is the principle behind it.
Yes, sir. Now all the children are addicted to mobile, even my children. So how they are behaving like by looking the cartoon or whatever fictions. They are in the fantasy world. So they are addicted to a mobile. So you got any of the addiction case in your that clinic or whatever in your service? You got such type of cases?
Yeah, you see, internet addiction is nowadays it's actually more than I would say an endemic rather than an epidemic. It's a pandemic itself. So everyone now, before the case, before the seminar presentation, announcement has been made before every seminar that keep your mobile phone silent because everyone uses the mobile phone. That is the pandemic in every scenario. So internet addiction, as per our ICD-10 international classification, there is a particular category for internet addiction, and in that we do behavioral therapy. We give counseling also for the children and also for the adults. And you would have seen certain cases being reported. Netflix addiction. One guy was admitted in Nimmans and he was given therapy for about 2 weeks. In my channel, I have explained about addiction, how to overcome addiction using Cinderella cartoon. I have explained with the help of Cinderella how addiction happens and how you can overcome the addiction. In my channel also one particular video I have explained. But internet addiction, a way of overcoming any form of addiction is disciplining shistu. So using mobile is fine, but there's one particular time of the day where you have to use the mobile. So now during COVID time, online classes, their students have to use the mobile. So even when at home, when children or they have to watch the cartoon, or watch the mobile, one particular time has to be given. It's called, we say, in the form of contingency management. Especially for small children we do. It's like nothing is for granted. It's like token. It's called token economy. So what happens usually, children salige togoltare parents. So nanige bike tegiskodi, nan matte first rank tegitini. So you'll say, first you buy me the bike, then I'll take first rank. That is called bribery. Alle lancha kododu. So that should not be allowed in the home. what should be allowed, first you take rank, then I'll get you the bike. So that is a token for the efforts which you have put in. So that disciplining can be bought in terms of token economy, which is part of our contingency management, which we tell with the parents. And most of the times it's the other way around. The parents have to tell the children that we are the bosses in our home. If you cannot directly say this, but non-verbally you have to tell that we are the bosses in our home, you have to follow our rules and regulations. That is for your benefits. That with multiple sessions we'll be able to tell them. Sir,
You told you have YouTube channel. Share your link, sir. Surely we will subscribe. Actually, give a big round of applause to the sir, because as a doctor, he created one channel and it is adapted to the innovative practice for the psychiatric patient. That's why he need a big round of applause, and he has taken the patent. Any other queries, sir?
thank you, sir.
Anything else from student side? Okay, sir, I thank Dr. Mithun for sharing his thoughts and views on new innovative clinical practice related to psychiatry. So, thank you very much, sir.
Thank you, thank you.
I would like to thank Professor Pradipa M and Dr. Viresh Chandar for being with us for the plenary session, and I also thank Dr. Mithun S for a wonderful session. I request our principal, Dr. A.R. Shabaraya, to present a memento and certificate to Dr. Mithun S.
I again request our principal, Dr. A.R. Shabaraya, to present memento to Professor Pradipa M. and Dr. Viresh K. Chandar. I request dignitaries to occupy the seats in the front row.
I request the chairperson, Dr. Gigi Jose, and the speaker, Dr. Aparna Sridhar Amin, to take seat on the stage. I request Kumar Prasad sir to florally welcome Dr. G.G. Jose and Dr. Aparna Sridhar Amin.
We have with us Dr. G.G. Jose and Dr. Shripati D as another chairperson. Dr. G.G. Jose, Vice Principal, DM, Vims College of Pharmacy, Wayanad, Kerala as chairperson. Sir is currently working as professor and head of Department of Pharmaceutics at Aster Dr. Muffens College of Pharmacy, Wayanad, Kerala. Sir has completed his B.Pharm and M.Pharm from NGSM Institute of Pharmaceutical Sciences, Mangaluru, and PhD from Jawaharlal Nehru Technological University, Hyderabad. Dr. Jose also has a patent and an authorship of one book in his credit. Dr. Jose is the life member of Association of Pharmaceutical Teachers of India and Pharmacy Graduate Association. Sir is also a member of Board of Studies of Kerala University of Health Sciences, Kerala. We have another chairperson, Dr. Shripati D. Sir was awarded degree of Doctor of Philosophy by Rajiv Gandhi University of Health Sciences, Bangalore. Under the guidance of Dr. A.R. Shabaraya, Sir has served as Assistant Professor in D.R. Karigowda College of Pharmacy, Hassan from April 2004 to September 2009 and in Karavali College of Pharmacy, Mangalore from May 2008 to September 2009. Thereafter served as Professor Srinivas College of Pharmacy since November 2009. Sir has 25 scientific research publications in national and international journals to his credit and has presented more than 5 scientific papers in national and international conferences. Sir is the recipient of Best Poster Award in 17th Annual Medicinal and Pharmaceutical Sciences Congress, Bangkok, Thailand in 2018.
I request Sir to introduce today's speaker, Dr. Aparna Sridhar Amin, Associate Professor, Department of Dermatology, Srinivas Institute of Medical Sciences and Research Center, Mukka, to the gathering and to chair the session.
Good morning to all. It's my privilege to welcome today's speaker, Dr. Aparna Sridhar Amin. Dr. Aparna Sridhar Amin, a consultant dermatologist, boasts an impressive 25 years of experience in medical field with a particular passion for medical and aesthetic dermatology. Madam is dedicated to providing a personalized care her patient, drawing upon her extensive training and expertise gained from renowned institutions in the UK, Australia and India. Dr. Aparna began her academic journey by earning her MBBS and MD in dermatology from Kasturba Medical College, Mangalore, Manipal University. Following her postgraduate study, she served as an assistant professor in dermatology at Yenapoya Medical College, actively contributing to the medical student education. Her quest for knowledge led her to pursue international training opportunities, including certified program in Wales, UK from 2005 to 2016 and in Australia from 2016 to 2017. She has acquired various international qualification including diploma in sexual and reproductive health from Faculty of Sexual and Reproductive Health UK in 2008. Membership of Royal College of General Practitioners with a completion of training after 3 years program at Royal College of General Practitioners UK in 2009 and diploma in dermatology from Cardiff University UK in 2012 and fellowship of FAEG from Royal Australian College of General Practitioners Australia in 2015. Dr. Aparna has also undergone specialized training in various aesthetic dermatology procedures including mesotherapy, laser and IPL safety, dermal filters and dermoscopy and skin cancer detection. Dr. Aparna has served as consultant dermatologist at Kaya Skin Clinic and Sparsha Super Speciality Hospital in Bangalore from 2017 to 2022. Throughout her career, she remains committed to the studying up to date on latest advancements in the aesthetic dermatology, regularly attending advanced training sessions to refine her skills in facial rejuvenation techniques using lasers, Botox, fillers, threaded lifts and microblading and medifacials and BB glow therapy. With this, I request Dr. Aparna Madam to start her speech.
Good afternoon, everybody. I would like to thank the chairpersons, Dr. Shripati and Dr. Jose, for such a good introduction. I would also like to address our respected principal, the distinguished dignitaries which are present, and the delegates. So the topic for today, which they have given me, is approach to adverse cutaneous drug reaction. I think it's a very pertinent topic, especially we have quite a lot of budding pharmacology students out here. So, especially because we are in this medical profession, we need to use medications in order to treat the patients. But apart from when we are treating the patients, we need to know what are the side effects and the adverse reactions as well. Because only if we know them, we can prevent or we can treat them. So I think everybody knows regarding this principle, that is primum non nocere. That means first do no harm. It is a part of our Hippocratic oath, which is taken by all the medical professions all around the world. That is, you shouldn't be doing any harm to any patients. So day in and day out in the medical professions, we tend to use medications in order to get the desired therapeutic effects. But in an ideal world, an ideal medication is a rarity, because even a simple paracetamol, it comes with its own side effects. So we all are familiar with this, that is the incidence of thalidomide, which is one of the worst examples of adverse drug reactions reported in the world history. So this was a medication which was given to pregnant ladies as a sedative medication against morning sickness in the late 1950s and 60s, and it was noted that following this, the babies which were born to these mothers had congenital limb defects as well as other birth defects. So coming to the topic as such, so what is an adverse drug reaction? It's an harmful or unpleasant reaction which results from the intervention related to the use of a medical product which warrants the prevention or specific treatment or alteration of the dosage regimen or the withdrawal of the medication itself. So The adverse drug reactions, it has been noted that it is the fourth leading cause of death. They are responsible for around 3 to 7% of the hospital admissions. And during the hospital stay, at least 10 to 20% of the patients, they at least suffer at least one adverse drug reaction. So as we all know that there are various factors which can influence these adverse drug reactions. Age is one of the things basically. So what exactly happens in case of your body surface area is much more in children. So that obviously affects the pharmacokinetics and the pharmacodynamics of the medications. The other thing is the babies generally they have thinner skin. And there is increased cutaneous perfusion and hydration of the epidermis in children basically. But as we grow older, there are certain changes which occurs. There is cutaneous atrophy which occurs. There is decrease in the body mass. There is reduction in the hepatic blood flow and the renal function. There is decreased activity of the hepatic enzymes. And obviously the polypharmacy occurs because as we grow older, we do tend to use more medications. So what are the patient-related factors? So as I was mentioning, pre-existing health conditions and comorbid factors, they do play a role in your drug interactions. Atopic people, generally speaking, are at more risk of developing allergic reactions. Genetics does play a role because if you have some abnormal alleles, you can have abnormal metabolism. Geography is another thing, like when you give any photosensitive or phototoxic medications to a patient living in hot, humid climate, it does tend to cause more of phototoxic reactions. So coming to the drug-related factors which plays a role on your adverse drug reactions. So it depends, sometimes the class of the drug which we are using. So we do see more incidences of angioedema which occurs with ACE inhibitors. Duration of therapy, so the longer you use, there may be changes in your, what we call it as the metabolism, which can increase the adverse drug reactions. The dosage, the higher the dosage, the more likely that you would land up with the adverse drug reactions. The route of administration, obviously if you're giving an IV or an IM drug, there is more of systemic absorption and there will be more chances of developing adverse drug reactions. The bioavailability also plays a part. So these are the few different types of mechanisms of the cutaneous drug reactions. So what we tend to say is immunological mechanism which is unpredictable. Under that you have the IgE dependent drug reactions, cytotoxic reactions, immune complex mediated reactions and cell mediated reactions. Then we come to the non-immunological which is predictable. In that you can have overdoses, toxicity, drug interactions. And then we come to the idiosyncratic reactions which is unpredictable again, in which you have the DRESS syndrome, the Stevens-Johnson's drug-induced lupus. So basically I'll be concentrating on the cutaneous adverse drug reactions. Among the adverse drug reactions, again, the cutaneous drug reactions, they constitute around 10 to 30% of the ADRs. Okay, there are loads of patterns which occurs in case of cutaneous adverse drug reactions. The most common of them are the exanthems and the medications. Anticonvulsants and antibiotics are the most common cause, but NSAIDs are the ones which are most commonly reported. So coming to, these are the, I think I skipped one. So these are the common adverse drug reactions, some of the common ones. I'm not talking about everything, I'm just concentrating on the severe ones. So drug-induced exanthems, urticaria, angioedema, fixed drug eruptions, erythema multiforme. So these these are the few severe reactions which I'll be talking about. So coming on to the drug-induced exanthems, it's also called as morbidly formed drug eruptions or maculopapular drug eruptions. This is one of the most common drug eruptions which occurs, which is noted. Okay, the incubation period can be up to 3 weeks after the administration of the drug. You can get this type of reaction. So sometimes you may miss it. Okay, because it can classically resemble a viral infection. So the patients, basically they may be misdiagnosed as viral infections. They typically don't show any systemic involvement. They can present with symptoms like fever, itching, as well as the blood can show eosinophilia. So variety of drugs can cause drug-induced exanthems. Some of the common ones are penicillins, anticonvulsants, sulfonamides, NSAIDs, and allopurinol. So what are the clinical features? So the onset of this reaction can occur any time between 5 to 21 days of the administration of the drug. So generally speaking, you can have a pruritic rash. So basically, the trunk and the extremities are involved. The face is typically spare. So what exactly do you get? You get what we call it as this maculopapular rash. So there is profuse eruption of these small pink papules, which is pruritic. So investigations, basically it is in order to rule out other things rather, okay, because this exanthem can be seen in other drug reactions as well. So basically, in order to rule out what we call it as stress syndrome, we'll need to do the underlying, to rule out organ dysfunctions, we tend to do the investigations. The viral serology, obviously, to rule out a viral pathology. If there is any doubt, then we tend to do a skin biopsy. Otherwise, we don't tend to do a skin biopsy in a drug exanthem. So what is the management? So management is obviously like you need to find out what is the causative drug, stop the drug. Generally speaking, when you stop the drug, the reaction subsides on its own without any problems. It may fade with a little bit of dry skin. Only symptomatic treatment with emollients may be needed, and only if it is pruritic, then you tend to use topical steroids. So coming to what we call it as urticaria, angioedema, and anaphylaxis. Now, basically, these are what we call it as typically an IgE mediated hypersensitivity reaction, which is which presents with what we call it as circumscribed skin edema and erythema. In case of anaphylaxis, it can be what we call it as the systems are also involved. So it is a life-threatening conditions in which you can have cardiorespiratory compromise, leading to shortness of breath, hypotension, things like that. Okay. So in case of drug-induced urticaria, sometimes you can have urticaria presenting with angioedema or with anaphylaxis. So as I was mentioning, it's the second commonest type of adverse drug reactions. In children, basically it is the food which causes these reactions, whereas in adults it's mainly drugs. And when you come to the drugs, it is the antibiotics which is most commonly which causes beta-lactam antibiotics, as well as painkillers, opioids, NSAIDs. Then during the perioperative period, you can have anesthetic agents or neuromuscular blocking agents which can lead to either urticaria, angioedema, or anaphylaxis. Recently, they have found that biologics are increasingly known to cause all these reactions. So what is the pathophysiology? As I said, it's an IgE-induced drug reaction. So what exactly happens is when the allergen it cross-reacts with the IgE, which is present on the surface of the mast cells. There will be release of the inflammatory mediators, and these inflammatory mediators will cause vasodilatation, it will cause smooth muscle contraction, as well as neuronal activation. So what are the clinical features which you tend to get in case of urticaria? So generally speaking, within around 24 to 36 hours of ingestion, you tend to get these reactions. But in re-challenge, when they are re-exposed to the same allergen, the reaction can occur much more quickly, sometimes even within minutes. So it is characterized by what we call it as wheals. Wheals are nothing but what we call it as these pale pink edematous macules, papules or plaques. Okay, they can affect any surface of your body. They can be of any shape or size. Okay, they are generally pruritic and they are what we call it as evanescent. Evanescent means these crops which comes, they normally last for less than 24 hours. So coming to angioedema, so as I was explaining, the principle of pathogenesis is similar, but the level of the edema which occurs, it varies. It's much more deeper down in case of angioedema. So basically, in case of angioedema, it can affect even the mucosal surface. So you can have what we call it as a swelling of the lips, you can have swelling of the eyelids, and generalized swelling can occur in different areas of your body. Especially we tend to notice angioedema in the hands, the face. As compared to urticaria, there will be lack of erythema. So now coming to anaphylaxis, which is a life-threatening condition, it's a severe allergic reaction. So if you don't get treatment, the patient can also die. Okay, so food allergies are one of the most common cause of this anaphylaxis, but other things which can cause anaphylaxis is obviously medications, latex allergy or stinging insects. In this case, what can happen apart from the skin being involved, in which case you can get the wheals, the redness, the itchy rash, you can have compromise of the airways, in which case you can have shortness of breath, you can have breathing difficulties, the patient may not be able to swallow. Okay, in case of the stomach being involved, you can have cramps, diarrhea, nausea, vomiting. Because of the widespread vasodilatation which occurs, there will be pooling of the blood which occurs, causing drop in your blood pressure, increased heart rate, and the patient can feel quite dizzy. So if you don't recognize these signs and symptoms and don't take the patient to the casualty, the patient can die. So the general approach is basically you need to find out what is the causative agent which is causing this urticarial reaction. So you need to, what you need to do is carefully document the series of events which has occurred before the reaction has occurred in order to find out what is the exact allergen which has caused these reactions. You can probably do a therapeutic challenge, but therapeutic challenge, it comes with you can cause the reaction. So generally speaking, therapeutic challenge is only done by specialist allergy clinics, and that also under supervised monitoring. Similar goes to the testing with skin testing. So what is the management of urticaria, angioedema and the anaphylaxis? The main thing is to stop the offending drug. Once you stop the offending drug, obviously the disease resolution occurs quite quickly. In case of urticaria, we start off with low sedating antihistamines. Now if it doesn't resolve with one antihistamine, we tend to add on another antihistamine. And if that also doesn't work, then we escalate it by using a leukotriene inhibitor or a H2 antihistamines. In case of refractive cases, we sometimes tend to use what we call it as cyclosporine, methotrexate, omalizumab, as well as dapsone and colchicine. Now, in case of anaphylaxis, this is the drug of choice, epinephrine, either subcutaneous or IM. This is a life-saving drug. Okay, so if anybody has anaphylaxis, according to the local protocols, you need to give them the subcutaneous or IM epinephrine. In some countries, EpiPens are available. If patients have had anaphylaxis more than 2 or 3 episodes, then they are advised to carry an EpiPen along with them so that they can immediately administer the EpiPen themselves. So coming on to the fixed drug eruptions. Now again, this is an adverse cutaneous drug eruptions which is characterized by recurrent, well-defined lesions which occurs in the same area each time the offending drug has been given. So it can occur within 30 minutes to 8 hours after the drug exposure. So these are the medications which can cause the FDE. There is a long list, so I'm just going to skip this. So what exactly happens, the clinical features? So it is a classical form of what we call it as a delayed type of hypersensitivity reactions, and it is mediated by what we call it as the cytotoxic T cells which are present in the skin. So commonly affected areas are either the lips, the genitalias, the palms and the soles, and what you typically notice is all these lesions, what we call it as this round edematous plaques which are present, and they tend to evolve into what we call it as this dusky color. So the investigation is oral provocation or patch testing. The treatment of choice is to stop the offending drug. If there are only few lesions, you tend to treat them with what we call it as topical emollients. But if there are loads of lesions, then you may need to give oral steroids. So coming to this condition which we call it as acute generalized exanthematous pustulosis, it is a drug eruption which is characterized by what we call it as rapid appearance of erythema and sheets of pustules, and therefore the synonym which is toxic pustuloderma. So these are the causative drugs which can cause mainly antibiotics, antifungals, ACE inhibitors, diuretics and anticonvulsants. So what are the clinical features which we can see in this? So basically, in case of what we call it as acute generalized exanthematous pustulosis, the onset is between 2 to 5 days following the initiation of the drug. You can have a prodrome of what we call it as the fever or malaise. The eruption generally occurs in what we call it as the major flexures like the armpits, neck, inguinal folds, inframammary areas. So you can get what we call it as this edema, which occurs with erythema, and on this edema and the erythema you can have what we call it as sheets of sterile pustules, non-follicular pustules. So you can see these sheets of non-follicular pustules which occurs. So when it becomes severe, sorry, I think it just skipped. Sorry about that. When the skin involvement becomes quite extensive, you can have what we call it as erythrodermic features, in which case you can have what we call it as heat loss, fluid loss, hemodynamic compromise. There can be secondary infection. There can be underlying what we call it as hepatic, renal or pulmonary dysfunction. But once the culprit drug has been stopped, all these reactions, they tend to settle within a few days, resolving with what we call it as post-inflammatory scaling. So in this case, we tend to do skin biopsy if we are not very sure of our diagnosis, in order to what we call it as differentiate this between AGPE as well as pustular psoriasis, because it can present with similar pustules. And then we can do what we call it as, in order to rule out any underlying organ dysfunction, we tend to do renal as well as liver parameters, etc. The management is basically to find out what is the causative drug and stop it. If it is mild, then we tend to use emollients as well as topical steroids. But obviously, in case of severe cases, we need to resort to what we call it as systemic steroids. And depending upon the organ damage, the concerned specialist needs to be involved. Now coming to erythema multiforme, it's a self-limiting but potentially recurrent disease. So in this, it is characteristically, you can see what we call it as target lesions present in the orofacial areas, and then you have what we call it as widespread necrosis of the epidermis. There are two forms, EM minor and EM major. In a minor, you don't have any mucosal involvement and there are no systemic features, whereas in case of EM major, you have mucosal involvement as well as systemic features. Sorry about that. So basically, in case of etiology, viral etiology is the main thing. It can be associated with what we call it as HSV infection. The other viruses which can cause EM, erythema multiforme, is adenovirus, CMV. Sometimes it can be associated with drugs. The other causes can be, it can be associated with pregnancy, lupus, sarcoidosis. So there is a long list of medications which can cause EMs. Out of that, antibiotics, antifungals, antiretrovirals. Then you have NSAIDs and metals. You have anticonvulsants, antihypertensives, CNS drugs, and miscellaneous drugs. So what are the clinical manifestations? They can, lesions normally evolve within 24 to 48 hours. Usually it affects the extremities and then the face, neck and the trunk. It has got a predilection for sun-exposed areas. Individual lesions, they tend to heal within 24 hours without scarring. Sometimes you can have what we call it as post-inflammatory hyperpigmentation. So what are the classical lesions which we see, which we call it as target lesions? So these are the target lesions, also known as herpes iris or Bateman. So in case of target lesions, you have what we call it as this dusky center, which you can have a vesicle or a bullae, and then you have an infiltrated pale area, and then it is, you have again an erythematous edematous halo. So these are typically what we call it as target lesions or bullseye lesions. So in case of erythema major, basically EM major, you can have, as I was telling you, you can have mucosal lesions. So in case of the lips, you can have what we call it as, you can have target lesions. Apart from that, you can have serous crusting. Okay, in case of the oral cavity, you can have what we call it as, you can have vesicles, bullae or erosions. Even eye can get affected. You can have erosions or conjunctivitis in the eyes. And the other mucosa also can get affected in case of EM major. So the prognosis is basically it has got a mild course. It generally subsides within 1 to 4 weeks. Rarely in case of ocular lesions you can have scarring. The treatment is to treat the underlying etiology. The role of oral steroids is debatable. It's only in case of severe conditions that we tend to use oral steroids. Antivirals, once the reaction has occurred, basically there is no role for antivirals except in case of EM which is associated with recurrent herpes simplex virus, in which case prophylactic antivirals can be useful. And oral EMs, obviously the treatment will be topicals. Coming to this condition, which is a severe condition, which is an immune-mediated hypersensitivity reaction, which can be life-threatening. It is a mucocutaneous reactions which is characterized by extensive necrosis of the skin. So pathophysiology, as I was mentioning, it is because of the extensive cell death which occurs because of apoptosis. So this is the pathophysiology which occurs. So the main cause of Stevens-Johnson syndrome can be drugs, infections, it can be malignancy related, it can be associated with collagen vascular disorders, but in around 25 to 50% of the cases sometimes we never find the causative organisms, the causative agent. So but in case of TN, around 80 to 95% of the cases are drug related. And in case of the drugs, these are the common drugs which have been implicated in TN, that is antibiotics, especially sulfonamides, beta-lactam, group NSAIDs, anticonvulsants, antiretroviral drugs, antimetabolites like methotrexate. So what is the spectrum of your SJS-TN? So depending upon the body surface areas, we divide it into 3 groups. That is the SJS, you have less than 10% of the body surface which is affected. In case of the overlap syndrome, you have between 10 to 30%. And in case of TN, more than 30% is affected. So usually you will have what we call it as widespread purpuric lesions or atypical target lesions. And the mortality increases as you grow from this spectrum to this spectrum. So what are the clinical features in case of SJS and TN? Usually the patient would give you the drug history intake would be anything between 1 to 3 weeks in case before you can get SJS or TN. But in case of re-exposure or re-challenge, the reaction can occur much more quicker. They can come with the prodrome of influenza or flu-like symptoms before the mucocutaneous reaction occurs. Generally speaking, you can have high temperatures in TEN, skin tenderness, photophobia and conjunctival itching. This may be the symptoms which may precede your mucocutaneous reactions. So this is what is the picture which we tend to see. So the mucocutaneous reactions can be quite severe and it can be quite scary to look at. So in this, the mucocutaneous reactions which you can see is multiple hemorrhagic erosions which are present on the lips. It can extend onto the buccal mucosa as well. In case of the rash, it can start off as like what we call it as the macules, and then these can turn into papules, You can get bullae. I don't know whether you can make it out, but these are what we call it as vesicles and bullae with confluent erythema. So the typical lesion which we will see is what we call it as targetoid lesions in case of Stevens-Johnson's TEN. So in this is a case of TEN. So TEN generally starts on the face and then it affects the upper part of the body. The patient can complain of what we call it as this macular erythema, which is quite tender. The patient will complain of quite a lot of skin tenderness, and then the skin starts peeling. So you can have sheets of peeling skin, leaving raw, painful areas. You can have what we call it as the Nikolsky sinus positive in this case. Now these are the signs and symptoms which when present early can tell us that the patient is going towards Stevens-Johnson's or TEN. So if there is confluent erythema, if there is redness which is affecting quite a lot of your skin, if there is facial edema or central facial involvement, if the skin is tender, if there is necrosis of the skin with epidermal detachments, there is mucosal crusting, there is swelling of the tongue. These are all the signs and symptoms which you need to look out for. So if these are present, then you are thinking in terms of Stevens-Johnson's or TEN. So what are the complications? Basically, you can divide it into acute and chronic complications. Acute, basically, because there is so much loss of skin, so the patient can have what we call it as fluid loss, electrolyte loss. This again can lead to renal failure. There can be overlying bacterial infections leading to septicemia. Because it's a hypercatabolic state, it can lead to insulin resistance. The systems can be affected, leading to pneumonitis. And the chronic complications can be that it tends to heal. The ocular lesion can heal with ectropion, entropions. You can have strictures in the esophagus. You can have phimosis, synechiae, orogenital ulcers. So early recognition of SJS and TEN is very much important. You need to find out what is the offending agent and withdraw it immediately. Multiple specialists are needed because it is multi-organ, okay? So you need to involve quite a lot of specialities and the treatment has to occur in an intensive care setting. So you may need what we call it as critical care intensivist, internal medicine, a dermatologist, infectious disease. To take care of the eyes, you will need an ophthalmology, dietitians as well as plastic surgeons. Sepsis is the major cause of death, so therefore you need to involve, do what we call it as careful wound handling is important. You need to do serial swabs in order to rule out infections. So these are the systemic medications which we tend to use in case of SJS and TEN, cyclosporins, oral steroids, etanercept or intravenous immunoglobulins. Some of the other treatments which have been tried is plasmapheresis and thalidomide. Now coming to this, another severe drug reaction which we call it as DRESS syndrome, that is drug reaction with eosinophilia and systemic symptoms. Okay, so it's a severe drug hypersensitivity reaction which is characterized by a rash along with underlying systemic upset. That is, hematologically you can have eosinophilia and solid organ damage. So what are the drugs which can cause DRESS syndrome? Sulfa drugs, antibiotics like amoxicillin, tetracyclines, anti-epileptics, painkillers. These are the few medications which can cause DRESS syndrome. And what are the clinical features in case of DRESS syndrome? So the picture can vary. Basically, you can have different types of clinical presentation. But the main thing is like the period of onset between the drug initiation and the rash. It can be quite long. It can be between 2 to 8 weeks. So you may need to do some digging about, and you need to ask the patient regarding what drugs they have used in the past 1 or 2 months. So in early phase, you can have malaise, fatigue, and the picture. You can have a papilla exanthem, or you can have a moderately form eruption, or you can have what we call it as an erythema multiforme reaction can occur with purpuric macules and atypical targets. So these are the systems which may be affected. So you can have what we call it as facial edema as well as lymphadenopathy. In case of the bloods, you can see eosinophilia. One of the most common organs which is affected in DRESS syndrome is the liver. So the features can vary from mild hepatitis to fulminant hepatic failure. And the investigations basically are to substantiate your diagnosis. That is, you tend to do a biopsy for histopathology, and the other investigations is according to the organ in order to find out the organ damage which has occurred. So the treatment in case of DRESS syndrome is stop the culprit drug. In case of skin, you may need to use high potent steroids. You may need to give oral systemic steroids as well. And if steroids doesn't work, then you may need to consider cyclosporin. And then you need to involve the specialist depending upon what organs are affected. So coming to the warfarin-induced skin necrosis. So as we all know, warfarin is a blood thinner which is used for treatment of DVTs as well as pulmonary embolism. So sometimes it does tend to cause what we call it as skin necrosis, which is very rare. Okay, so in this condition there is paradoxical blood clotting. Because of the blood clot which occurs, it can cause necrosis of the overlying skin. It does tend to occur in around 1:1,000 patients who have been prescribed warfarin, more commonly in between 50 to 70 age group, and more commonly seen in case of obese and perimenopausal women. So what do you see? So the onset is between 2 to 5 days of warfarin therapy. The patient can complain of a painful bruise, okay, and then this can get aggravated to what we call it as this bluish black area with a red rim, okay, and following that you can have what we call it as blood blisters, and it can break open to form full thickness skin necrosis. The affected areas which are commonly affected are the breast, the thighs, buttocks, hips and the abdomen. So the mainstay of this warfarin necrosis is to stop the warfarin. You may need to switch over to heparin because these patients will need anticoagulation. You can use what we call it as vitamin K, protein C concentrate or fresh frozen plasma in order to reverse this effect. In case of large skin necrosis, you may need to resort to what we call it as plastic surgery or skin grafting. In case you need to start the warfarin, you need to involve a specialist hematologist, and in continued monitoring supervision, you need to start the warfarin back again. So that comes to the end of my the hard topic, I would say. So what are the challenges? Just on a lighter note, what are the challenges which we have in the day-to-day practice which is related to your medication prescribing. So as we all know, all patients nowadays, they will come with a list of queries because they have gone to the internet, they have done searches, or they have gone to YouTube's, or they have listened to these bloggers. So generally speaking, in our skin OPD, we have these patients coming in with loads of query regarding what skin routine am I supposed to do, because they have listened to certain celebrities, okay? So they have used everything under the sun, okay? And they land up with problems. So these are some of the challenges which we face in our practice. The other thing is I think this is the bugbear of all the chemists, because they say that they can't recognize or they can't make out what is the medication which has been prescribed by the doctors because of the handwriting, basically. Okay, so that is one of the things which can lead to medication errors. We call it as prescribing errors. So the patient may get, you might have written something and the patient may get something else because the chemist he can't make out the handwriting of the doctors. Okay. The other thing is communication problems. So because of time constraints, sometimes you are not able to communicate with the patient properly. So you might not be able to elicit history from the patient. You might not be able to you might not be able to get those drug interactions which can occur. So why do we need to be careful regarding our prescription? Because drug-induced reactions or adverse drug reactions, there are common reasons of litigations. See, the manufacturers, normally they will give you a whole list of these side effects, okay, which comes in a piece of a paper. I don't know how many people they go through these list of the medications. I'm certain that most of the patients, when they are prescribed these medications, they don't go through those lists, okay. So they wouldn't be aware of what are the drugs, what are the side effects, okay. And then when they land up with these side effects, they can put a case or they can put a litigation against the prescriber. And it is very easy because the buck stops with the clinician, basically. So what are the medical pitfalls? Basically, it's like you need to take time in order to tell the patients regarding the potential side effects. You need to be aware that whether the patient is having any allergies. So you need to take a careful history and document that. Okay, you need to know about the interactions which are present. So these are the medical legal pitfalls which are quite common. So in conclusion, clear guidelines and protocols for the use of the medications is important, especially when you are working in a hospital setup. Carefully defined care pathways need to be provided. The most important thing which I would stress upon is like all the doctors or the clinicians, they need to take a drug history and they need to document it in the medical notes. Most of the times we find that this is missing. And as I said, like we need to be alert for any allergic reactions. And in conclusions, I would say that prescribing is no longer the remit of the doctors itself. Everybody who prescribes need to take the onus and responsibility for their prescribing. So, thank you for your patience.
I timely appreciate and thank Dr. Aparna Sridharamin for spending and helping our delegates with your most informative talk. Thank you, madam. Now the session is open for discussion.
Namaste, ma'am. In the beginning of the session, you told ma'am that small children's skin is having high cutaneous permeation of the drugs. So, high cutaneous permeation might also cause some of the severe side effects. So, how can we prevent these extra side effects or ADRs in the high extent of cutaneous permeation in the skin?
See, in case of your children, we do tend to go with milder creams. Okay, so if we are using a potent steroid, we tend to go into mild potent steroids rather than going into high potent steroids. Especially in these face areas and things like that, we tend to use hydrocortisone. Okay, instead of using betamethasone or clobetasone. So if the same reactions we see it in an adult, I would probably tend to go with a moderately potent or a high potent steroids. But in case of a child, I will reduce the potency so that we don't get these side effects. Okay, and we try to see that we use only a little bit. We tend to educate the parents saying that in case of you go by fingertip units, isn't it? Okay, so in case of using a full fingertip, we tend to ask them to use just a quarter of it or half of it. So we tend to reduce the amount which we are using, and we tend to use the strength which we are using. We tend to go lower in it.
One more question is there, ma'am. It is like some will have very shyness during in their genetic organs, or somewhere it will in the skins are very sensitive for the side effects. So some rashes will be there or severe redness and all will be there, but they are shy to express it. So what are your suggestions, ma'am, that how can they express, how they can express their feeling, like how the confidence they can get to ask or to tell that we are having some problems, but how to express that?
See, generally speaking, when they come to you as a doctor, okay, they are coming with that faith in you and trust in you, okay, basically. So only if they have that faith and trust in you, they will come to you, isn't it?
Yes.
Okay. And then when you are making them comfortable, basically, what we tend to do is like, I tend to take a nurse along with me, okay, close the door, make sure that they are granted their privacy, okay, and then we tend to ask them like if they are okay with it, because we do need to see what kind of rash it is. So because they are obviously what we call it as genital dermatosis itself is a big topic, okay, there are quite a lot of genital dermatosis which can occur. So unless and until we have a look at the lesion, it's not possible for us to make a proper diagnosis. Unless we get a proper diagnosis, we are not able to treat it. Okay, so we need to take the patient in confidence. Okay, make sure that they are comfortable with you. Okay, offer a chaperone if they want to. Okay, and then ask them if they are okay with us to examine them. Then examine them. Okay, but you do need to take them in your confidence and take their consent, because without taking their consent, it would be an implied consent. But with the implied consent, you need to make sure that you examine the patient, because without examination, making a diagnosis and then a management plan is not possible.
Thank you, ma'am.
Ma'am, I have one question here. You explained very nicely about the adverse reactions about the drugs. But what about the cosmetics? Every day we are using facial, lipsticks, all those things. Do you have any such reports on that?
See, we do I concentrated mainly on the severe reactions which we tend to get. But obviously because of the cosmetic overuse, sometimes we can have what we call it as acneiform eruptions, because the patient has used quite a lot of occlusive medications on the face, or you do tend to get what we call it as folliculitis, because they have used oily products on the scalp. So you can have folliculitis of the scalp. Sometimes we do tend to get what we call it as cosmetic induced hyperpigmentation around the lips. So these are all the things which we do tend to encounter. But the topic today was more of severe reactions, so I didn't concentrate on all these acneiform eruptions or hyperpigmentation reactions. So we do tend to get all these patients, we do need to take a careful history regarding all the things which the patient has been using, apart from drugs obviously. So whenever a patient comes with, like for example, if they are coming with hyperpigmentation of your face, okay, so then we do tend to ask them like what products they have used, have they used any photosensitizing medications, or even fragrance mixtures or perfumes what they have used. Sometimes they can cause what we call it as Ryle's melanosis. All these conditions are quite known to occur associated with all these cosmetics. So history again is very, very important. Okay.
Another question. You are explaining dose related and drug related somewhere. This adverse drug reaction. Is this can be related to the biotransformation metabolism? Is there any dose that can exceed and that biotransformation may lead to this adverse drug reaction?
I'm not, I think it's something which is probably I need to have a look into it basically. But you guys might be more, what I would be specialist in telling about it. So I think I might need to jog your information from you all actually.
Madam, then one more question.
Yeah.
Most of these cases, this ADR can be misunderstood with normal dermatosis or even sunburn or psoriasis.
Yeah.
How we can differentiate at single investigation?
We normally, as I was explaining, that we tend to do what we call it as if there is ambiguity regarding the rash, okay, then we do tend to do what we call it as skin biopsy. The biopsy is the investigation of choice, especially in dermatology. So if we have any, the characteristic of the rash is not very specific to that particular conditions, then we do need to do a biopsy because that is the gold standard for diagnosis.
Regarding the management, mostly we will go for that oral or cutaneous corticosteroids. Any other options?
We do tend to use immunomodulators now. So like I was explaining in case of your Steven Johnson's or TEN, we do tend to use cyclosporins. Sometimes we do tend to use methotrexate as well as immunoglobulins has been used. Rare cases they have used thalidomide and things like that. So but those are only few cases they have documented that other medications. Only if they are, the treatment which we tend to use is steroids mostly, okay, but if that doesn't work, then we tend to use either cyclosporin, methotrexate, immunomodulators.
Okay, thank you, madam. Any other questions?
I would like to thank Dr. Shripati D and Dr. Gigi Jose for being with us as chairperson for the plenary session. I thank Dr. Aparna Sridhar Amin for the wonderful session.
I request our principal, Dr. A.R. Shabaraya, to present a memento and certificate to Dr. Aparna Sridhar Amin. I request our principal, Dr. A.R. Shabaraya, to present a memento to our chairperson, Dr. Shripati D. I again request our principal to present a memento to Dr. Gigi Jose.
Thank you, sir. We request our dignitaries and delegates to have lunch and join us for the afternoon session at sharp 1:30 p.m. and valedictory program will commence at 2:15 p.m. Thank you.
Hello.
Hello.